Let's go. Sheldon, just like his epic, just wants to get to it. I think it's probably, yeah, I think Sheldon Morris, Dr. Sheldon Morris presented last year, always has such interesting data to show us. So for, newer folks, this will be wonderful. But I have an introduction that may be a little old, but we'll go with it. Dr. Morris is a professor in the Division of ID as well as Family Medicine. He went to medical school at the University of British Columbia. So there's always a lot of Canadian stuff that he likes to talk about with us. And you'll hear the accent. It's wonderful. He got his master's of public health at the Harvard School of Public Health in quantitative methods, where he majored in analytic methods for epidemiology and clinical research. He did a preventative medicine and STI epidemiology. I'll call it a fellowship. I think it was a fellowship at UCSF at Berkeley. And then he also did a fellowship at the STD control at the San Francisco Department of Public Health. This probably feels like a lifetime ago. And now Sheldon has led illustrious life here at UCSD for the last 20 years, of course, which I have very little information about in front of me. However, I've been fortunate to work with Sheldon in a lot of early PrEP studies that involved the California Collaborative Treatment Group. And I thought I saw that Alan McCutcheon was on, one of the founders of that. So we're taking us back. There's Alan, a little history there for some of the new folks. And I hope that Sheldon will tell you about some of the other amazing work that he's doing. I think today that he's talking about a CHIRP funded research project on long-acting injectable PrEP, but I'll let him get to it. That was a little bit of winging. So,
Wow. Thanks, Jill. Yeah, that was more than I was going to
good,
say,
good.
but it was kind of like that. That was great, and thank you so much. Yeah, it has been. This is my 20th year, at the AVRC and at the university, so I'm like, wow. I mean, this is crazy.
I
Yeah,
think
there's
you get
this.
a jacket. I
Yeah,
think something like that.
right. I'll wait. I won't be holding my breath for that. Yeah, so this is a project that we've been doing for the last few years. We've had actually a fairly long-standing relationship too with the Los Angeles LGBT Center that we've worked with several projects on. So this was something that we decided another submission that we did, and we also have some people from UCLA on board to look into how we could maybe accelerate, long-acting PrEP being implemented in Southern California was kind of the idea. Okay, let me get this going. And then here's the team. I want to recognize them right up front because they've been, instrumental in getting this done. I
Sheldon, I
really
don't think
want to.
your slides aren't displaying.
Oh,
Yeah,
okay.
I had a feeling they were, and then they went away.
Well,
I
let
can
me
see
go back.
them.
Oh, oh my, I'm
You,
so sorry. I
you see
had,
them? Yep.
yes,
Yeah, yeah, they're
I'm
Okay.
gonna
there.
stop. Dan,
Can you see me?
Dan and Anik, I'm gonna go.
So a big shout out to Jessica Montoya, Daphne Palton, who've been, really brought in the expertise in implementation science and qualitative methods for this project. And obviously our wonderful Christian Turner, who's our pharmacist at Owen Clinic, who of course does a lot of long-acting injectable stuff over there. Melissa. Daphne also helped, with a lot of these slides, putting together some of the qualitative data that I'm going to present to you today. And then at the center, we have Bob Boland, who's a longtime medical director there. Mike also helped with these slides and helps organize all our meetings. Right, so sort of had a research over there at the center, and then from UCLA, Ian Holloway brings in some policy expertise and help again, with our study team. So just a great team to be working with. So you've met them now. I'm going to talk about our research goals and sort of our preliminary findings. I guess we're about a little over halfway through now, but so we're making a lot of progress, and but some interesting information that we're getting out of this. Don't really have to spend a lot of time talking about injectable PrEP. Everybody's had probably heard about it many times and know the products, but I think that, what struck me here is how cabotegravir has been around for quite a few years now. And so, we really thought that this would be something that could be very useful. And I think I get the sense it's generally underutilized right now because of various issues that I'm going to talk about. with lenacapavir coming on board last year, there's again more potential, especially with the more sort of spread out dosing. And just in terms of a quick sort of review of why, how it compares to our oral PrEP, I mean, it's really the dosing schedule that provides some more flexibility in people's lives, going up to every 6 months with this to go, and which would be, for some people would be a real boon. And one of the things we hear at both uh, when I talk to in some of our interviews with both HIV infected folks and PrEP folks is stigmatization of taking a daily medication. And so there's a real help with that if you're only having to think about it every few months or so. I think in the studies also shows, very high efficacy because of, well, mainly because of an adherence issue, with daily oral PrEP. And, if you're taking it all the time, it works just as well, almost pretty much, right? So, but people don't always take it, and they take breaks, and so so they're really in the long run, if you could stay on injectable, you're going to have a better sort of efficacy signal. There's some unique side effects that come up later too in some of the discussions and interviews we had with our providers about local site reaction nodules with the injectables. But then with the orals, there's also concerns about renal bone toxicity and also just GI toxicity because they're taking oral medication. Um, with the daily prep, of course, there is flexibility around, okay, I'm not really, at risk anymore. I want to take little breaks. You can go off and on. You can do 2-1-1. And there's, it's a little bit more flexibility about how you dose that. And then with injectable, you really can't really miss those windows too much. That is sort of really critical in terms of then we get really worried about this resistance potential from the tail if people just discontinue and disappear. And that would be a real issue with especially cabotegravir if we're thinking that it's integrase inhibitor. And if we had, community transmitted resistance to integrase inhibitors, that would be a big deal. That's maybe another on a benefit of lenacapavir being a different class altogether, maybe that wouldn't impact that as much. We haven't seen that much resistance at all from, the daily PrEP use, at least not that I've heard of yet. Big cost difference, though, very expensive still the injectable, and that'll come up over and over again when we talk about, how this is impacting implementation pieces. I mean, obviously you get generic Truvada very much cheaper. Obviously, you have to come to the clinic to get that injection or come to a healthcare provider. I think you should be coming to the provider too for oral PrEP, for your regular STI screening, et cetera. But, it's a little bit flexible though on the timing of that. Okay, so let's go on to what we were doing. We were thinking of building capacity of injectable PrEP to communities in Southern California by forming a learning collaborative. We really were trying to target community pharmacies and clinics that hopefully we were really trying to get to sort of PrEP deserts if we could. But, we kind of would take all comers who would participate and are still open, honestly, to different people joining. It's a 4-year project, CHIRP funded that you heard about. So really, that it's been great to be have the state funding right now. Uh, we also put a sort of a embedded in that we really wanted to focus on transgender and non-binary people, Black and Latinx, MSM, as sort of a target group to also do more in-depth uh, focus groups, interviews, and figuring out better ways to expand use of injectable PrEP. And our main outcome, I guess, was trying to increase uptake at these community sites. And we'll see if we ever get there. The sort of the rationale behind the grant or this sort of ethos was sort of an economic concept of supply demand. I think this came from Ian Holloway more, but the idea was we should be looking at both sides of the equation. Supply side being the providers and that they can provide injectable PrEP, making it available and having a place where people wanted it that they could go and get it. And then the demand side is, having actual patients that want to take injectable. And so how do we encourage that use? And that was kind of the other, so we call demand side. And then this is our kind of original aims, more or less stuck to them. I mean, we followed the EPIS framework. So there's an explore, prepare, implement sort of aims one, two, three. And so we've largely completed aim one, I think, which is really to do look at both those supply and demand side in terms of willingness and readiness for stakeholders and patients to adopt long-acting injectable PrEP. Then we moved into aim two, where we're doing on the supply side, building our learning collaborative, having sort of educational meetings every month, and feedback to try and build, sort of confidence and troubleshoot with sites to try and get them up and running. And then on demand side, we haven't got this done, and we're just ready to start this year, which is more focus groups and qualitative work to look at, okay, well, how would if we were going to try to increase use, what sort of avenues do people, get their HIV prevention information from? Where would they look and listen in their daily lives that we could get that message out? That's kind of what we want to get with that. Maybe coming out with some marketing messages at the end. Not that we have any funding to do that, but that's kind of like maybe another step. And then in the final, aim three is really looking at how well we do over time and see if we change the needle in any way. Here's some of our activities that we've done. I mean, the first thing we did is create a community advisory board, which is, largely just, again, from our target populations. We have Latinx and African American MSM on that board from Southern California. We then, had established our learning collaborative for the community pharmacies and clinics. Then we did some surveys of both those providers and some community members. And so some of the outputs that we're getting is we're going to identify barriers and facilitators. We'll talk more about that today. Later, we're going to try and inform marketing strategies for PrEP. We haven't got to that yet. And then measure the change over time that are reported through our partners in the Learning Collaborative. Just to start off with, quick talk about our community advisory board. That's been going on over a year now. We have quarterly meetings. We just do Zoom meetings because people are disparately over Southern California, but more heavily sort of LA and inland. We do talk about our progress, our plans. We try and, get feedback, and we do surveying of our community advisory board. And, we've got a lot of questions in the survey, but, I just wanted to pick one out in terms over those 5 different quarterly meetings over the past over a year. There's some consistency that this problem is important to the community, where 5 is sort of high importance. So I feel like we've maintained that momentum that's an important issue for the community to continue this project. This is kind of reiterate some of those things, who we are, funding, the Learning Collaborative and where they're from. So just where we have these pins is where we actually have Learning Collaborative members and where we're trying to recruit people from, which is a little challenging sometimes, how to recruit from areas where we don't have necessarily a footprint. But LA, San Bernardino, Riverside, San Diego counties where we have sites. One of the issues that came up with us when we were trying to actually recruit community members was that, well, we can't just go out and how do you do flyers? How do you do that? So, but there's so many bots in social media, et cetera, that we'd get flooded with this in the first, we'd have to like stop and restart again. It's just so hard to do recruiting now because of this sort of interference. I've seen it before in previous studies too, and it's just hard to avoid. You have to kind of verify if people are real, and it's not an easy task sometimes. So that's kind of become more of a challenge. This is oh wait a minute, lost my slides. I hit a button. Back to this. There we go. So this is a slide that Micah made actually for a poster. And it kind of gave the experience of one of our sites and talking about what how they had experienced trying to deliver long-acting PrEP. I know it's a busy slide, but it goes like this. The doctor prescribes a long, talks to the patient about long-acting PrEP, and the patient's really interested, so they give them a prescription. They send it to their community pharmacy, and then the pharmacy gets the message, oh, they're not allowed to get that prescription, and it needs to go to a specialty pharmacy. And if they're in an outlying area, that specialty pharmacy tends not necessarily close or convenient for that participant or patient. They also, get a prior authorization request to the physician, which that takes time to complete and submit. And while that's all being done, the patient's calling, like, what's going on? And there's sort of this lack of transparency, they say, about what's going on. And then they get it 4 to 6 weeks later, they get the medication at the office that the patient has to come in. And then they come in and they go, well, forget it. I'm not interested anymore. And then they gets a big bill because, of course, that was something that was in, and these are really expensive medications. So, that is a lot of frustration for people trying to deliver the medication, and so it sort of is a detractor for wanting to do it. This is when from our original grant, something uh, that was put together by Christian about how they manage it on because the idea was, wow, we do a pretty good job here, I gotta say, at doing that, and it's because of the hard work and organization of the folks in the pharmacy at Owen Clinic. But to make how to deliver this in sort of the say ideal way, you have to go through these different steps and have it flow in a way that keeps everybody informed and in a predictable way. I know again this is busy, but this is all the things that happens. You have to evaluate people's and coverage and insurance and making sure that there's a way to pay for it, whether that be a pharmacy benefit, a medical benefit, and that becomes a big issue actually with a lot of pharmacies about how it is actually covered by the insurer, whether they need patient assistance programs to help pay for it. Then there's the whole education and counseling piece that goes along with both HIV, the whole HIV prevention kind of delivery, and then what to expect and what with this getting long-acting injectable. In this case, there was only Apretude at this time, so we talked about securing Apretude, getting it to the pharmacy or the clinic where it can be administered, getting the patient in, scheduling them, and then further follow-up monitoring them for, where they're going to come back. And then you have to make sure that they don't, miss doses. What happens if they miss a dose? So there's a lot of sort of follow-up that goes into this. Again, something that's challenging for a lot of things. That doesn't mean we expected everybody to do this. I think the idea was, let's see what you can do and how you can make it happen. So, going to talk about where we are with the Learning Collaborative, a little bit more about that and some of the data we derive from them. What's a learning collaborative, you might ask? Well, it's sort of an approach which involves sort of organized learning sessions to facilitate folks to try and apply changes in their setting. It involves both peer-to-peer learning because hopefully the participants will each figuring out different paths and they might then inform the other people also sort of as a support group to kind of like walk through those issues and feel that they're not alone. We have expert guidance where we try to bring in speakers every month to try to get at what we see may be problems or things that might help with them implementing at their site. And I think we've kind of broadened that now to just try to address some of the bigger structural sort of issues and how is there any way that we can feel more empowered in that piece. Obviously, our focus is and in general for our learning collaborative is just to accelerate or adopt evidence-based practices and improve outcomes. So we've been meeting about a month, a year every month. We've had about 23 members join and then about 12 show up each month, sort of mix up of who can make it. Who we've had presenting as the experts, we've done a lot of sort of like navigation pieces about how they manage insurance stuff. And San Isidro has been really great about showing how they manage folks that are largely uninsured. We have it from the LA Center and some of the community pharmacists are on the leading edge who are part of the group who've been really trying this for the last few years, also having it because they can give us some real, sort of experience that they have and what roadblocks they're facing. And then realizing, that some of the biggest issues have been sort of like availability through and so we've had the pharmaceutical companies come because we wanted to give feedback. So I saw that there may be a disconnect between how they want to see their product, success, but the way it's on the ground. So we wanted to create a dialogue between them and the pharmaceuticals. And so we had Vive, and then when Yestigo came out, we had Gilead come and kind of detail the product for one because they had to introduce it, and then again feedback, hopefully to try to avoid some of the problems that have happened with cabotegravir. But although it seems very similar. The other thing we found was, yeah, if it's a structural issue, what else is being done? So we brought in state senator office to talk about and give feedback to them about our problems. And they were going to do, I think it's AB 54. I forget the bill they are putting in to try to say that insurance couldn't have pre-authorizations for PrEP and to try to make it a pharmacy benefit only. So this did pass, but it went to the government and was vetoed. So it's not law. And I don't know if there's going to be that's going to come back. But again, we wanted to feedback to our legislators about, ways that they could help the situation. We also brought in some of the policy people from the center to talk about some of the, where they're working on, and particularly with PBMs. And I actually took some slots because this was just this week, and I wanted to think, which were very interesting. Health departments also about, how they wanted to, what's their approach to LAI. We wanted to get, again, to some of the more other Southern California. We've had a sort of an open invitation to the different counties. This is, yeah, from this week, talking about the role of pharmacy benefit managers as the middleman. And I don't know, you may know this more than me. It was kind of, I've heard of it, but I hadn't heard it, that these are really the people that kind of control the distribution of medications between the pharmaceuticals and the pharmacies. And they're kind of like taking their cut, and they can really, regulate, how much the pharmacies get. And can be, again, a big problem in terms of the finances. And I took the screenshot of this particular quote that they had from a pharmacist saying that, I've had several patients that have come here and wanted to get, presuming Apretude. I have one on my desk that I'm trying to figure out how I can link him up with care because the doctor's office got the prescription approved, but it's a $150 loss on the cost of medication, and I can't lose $150 every day they come. And then in the actual session, we had people saying, well, that's even cheap. We're losing up to like $700 per person with the current reimbursement rates. So this is a big issue that hasn't really been solved. And I was trying to think, well, that's our next step, is how do we get pharmacies pharmacists to be able to practice at the top of their certificate and deliver this medication and get reimbursed for it. And that is one of the biggest issues that we're seeing, that we're hearing about. Here are sort of the characteristics of the folks that we have in the Learning Collaborative, sort of LA County, and going sort of inland, Riverside, San Diego. We have San Bernardino. I think we still have San Bernardino. But they come from a different, there's a lot of pharmacists, but also, a variety of other healthcare workers that are part of this. They just representing sort of their institution. We have like small one shop community pharmacies all the way to, ones that have more chains. This is just, again, we do a lot of surveys of our collaborative group. This kind of just tells us that they seem to find there's value in the learning collaborative sessions. These are the ones up to September, generally getting ranked as very close to satisfied, very satisfied with the presentations and how it's going. And also that they continue to see there's value in this endeavor. So again, continue to have high acceptability, and appropriateness. And then the other questions we've done in sort of is asking them about their willingness and readiness to adopt long-acting PrEP. And again, we see a lot of enthusiasm continued with our learning collaborative members, our clinics and pharmacies. Again, rating that very high, that completely agree about acceptability, appropriateness, and feasibility. But what's interesting here a little bit is that our community advisory board, which does sort of a similar survey, they're they've lost some steam. Maybe this is because we're getting the feedback, to them, and maybe that frustration's coming through. That there's a lot of issues that are you come across that we don't feel like we necessarily have the tools to fix if there's structural issues. So some of that's feeding through. So there's been some decline in their sort of idea of if that's feasible. This is sort of our base. I'm trying to do some surveys now about where they're at in terms of current, PrEP delivery and HIV prevention things. So here, mainly we have community pharmacies and commercial clinics that are sort of that as they identify. About 7 of the 12. So we only had about 12 people in this on this last one. That their focus is LGBTQ plus health. And then, of the people answering about, what percentage of their patients are transgender folks, it's about 1 to 3%. I just put in ranges because they're small numbers and they're quite different in terms of ranges. How many of our sites, again, answering about Latinx clients, 15 to 70%. Percentage of patients that are African American, 1 to 10%. So we're getting to clinics that do serve some of those target population we're talking about, people that we really want to help or get informed about how we can expand PrEP in. And then they are giving injectable PrEP. So, about a third of those sites are providing PrEP to transgender individuals, Latinx, and African American MSM. So that's kind of one of the things we're trying to measure. And then getting down to sort of like their PrEP prescribing volumes, a lot of them, I think that some of the clinics don't consider themselves as dispensing oral PrEP. So that's why they didn't answer this as saying that they provide it. They probably provide prescriptions, but they don't actually deliver it. But we have sort of this two groups. Like we have, sites that are sort of like these smaller volume PrEP providers. And then we have ones that are very large, volume PrEP providers where the 150 to 1,000 prescriptions per month. Some of our ones actually have multiple pharmacy sites. And so they're more like a small chain than a standalone community. Only 5 of the 12 were actually providing injectable PrEP prescriptions in the past month. But again, those split up into groups of small numbers versus some larger numbers. So that's a sign that at least that some of these are very active, prescribe, I guess, providers of injectable PrEP. And then, important to us to know is whether it's getting are we getting better or are we getting worse? And sort of, so about a third of them saying that they're improving or they're increasing their injectable PrEP numbers. And just to kind of get, what else do people do for HIV prevention, in terms of HIV and STD testing and treatment. What I thought we had originally toyed with making a Fabian about DoxyPEP, but we just couldn't fit it in budget-wise. But so we just asked some questions. But DoxyPEP really has been taken up. It's really interesting in almost everybody providing DexyPEP in their sites. So now we're going to explore some of our our interviews, our in-depth interviews with our providers on the supply side again. Getting to aim one, willingness and readiness for LA PrEP. These are the slides. These are the nice slides because they were made by Daphne, Melissa, and Micah. So these were key informant semi-structured interviews. We did about 10 healthcare providers in Southern California. We did, just to reiterate some of that we did the EPIS framework ideas and framework for our doing our analysis. Is there another box? Then, I think there we go. Rapid qualitative analysis methods applied. So I'm going to talk about some of what we learned in these qualitative analysis about innovative factors, outer context, inner context, and bridging factors that influence uh, their ability to deliver long-acting PrEP. So let's get to some of those interview results. Here's some themes that came up for facilitators in innovation factors. I think we talked about that privacy is enhanced through giving injectables, and takes away the stigma of taking that oral dose medication. They also talked about that this could be a good benefit for people that are, let's say, hard to reach. I think I'm thinking people that might have more disorganized lives than can't make it in. And I know that some of the CHIRP-funded projects are specifically trying to focus on this group and population. Um, reducing the burden or having to get prescriptions all the time, take daily pills, carry pills with you could be a real benefit there. They talked about superior efficacy or effectiveness, I guess, in the real world setting. And they were reflecting on some of the data that's come out of the studies and head-to-head studies. Side effects for those that sort of are suffering like GI side effects or are not tolerating oral meds, then this is again could be an alternative. So that was considered to be another innovative factor. Here's some barriers, though, that they saw, and the same on the flip side, the side effects that people have, injection site pain and nodules. More invasive, who likes getting a shot, honestly? If it's only 6 months, not so bad, but again, if it's a painful nodule, then that can be very bothersome for people, cosmetically as well. Concern about resistance, and that's still sort of out there in terms of people worrying about, people having that long tail of subtherapeutic levels. These are some of the quotes that were coming from our interviews as well. And they talk about all the logistic challenges, which I kind of had alluded to before, scheduling, workflow, staffing. These are sort of things that come along with prescribing that, and delivering that are a little hard. Doing the printing just takes a lot of my time, they say. Inner settings, things that happen within their setting themselves in their clinics and pharmacies. There's negatives and positives. Will tend to be a little on the negative side here. Really getting back to that idea of needing to do all the tracking and the navigation piece, trying to get the medication coverage and stuff. And we've heard instances and where they would call to the insurers to get a verbal that they were approved, deliver the medication, and then the written is that they were rejected. So and then they're out 10 grand or whatever, right? So this leeriness about making sure that they have a written authorization before they deliver what came out in some of the sort of discussions that we've had in the Learning Collaborative. Resources, big issues, sort of lack of space to deliver injections, having staff to deliver, manage and monitor, and then being able to train people on those practices. We had to hire 8 people to cover the whole entire country. So that was kind of one of our groups that obviously has multiple, but there's limits to how much, staffing they can increase, because it doesn't necessarily generate fine, as we talked about, that there's some people taking losses for this because they just want to be able to deliver, injectable. So that they're not sure if it's financially feasible or sustainable. Maybe if they could get a flow of patients and the billing was right, that could change, though. They wanted some, just champions and leadership and I think they felt that, part of that was coming from our side. Outer settings, these are sort of some of the big issues. I see mainly negative stuff again, but they just worried about patients being able to make it to these scheduling visits and or whether they could, there's always these competing. I think this happens with all healthcare, though, really. But, especially when we're talking about every 2 months, it is pretty frequent. You don't go see your doctor usually every 2 months unless you really need to. Uh, and they thought, well, maybe it could be rigorous. If we were reimbursed enough, they could probably create this as a revenue stream, and that would make that happen a lot easier if there was a financial incentive here. The buy and bill model is particularly risky. That's where you have to buy the medication from the PB through the PBM, and then you're stocking it. So that means you're paying a lot of money up front for delivery. So if you don't use those product, you're out all that money if it expires. So it's a pretty high risk sort of financially for community pharmacies if they were going to do a buy and bill system. Uh, I think policy changes are sort of bigger structural issues, really about insurance, programmatic issues, a lot of bureaucracy to get through to get that, product to the patient. And then just the whole idea of getting reimbursed, insurance coverage policy is different between different for different patients. And you don't know, like I said, difference between a pharmacy or medical benefit and how that's going to be paid. And if they get rejected or if something happens, like I talked about, you can be out again for that cost. Or patient gets a big bill, which always makes people very happy, as we know in practice. Bridging factors, things to help make that. Mainly, they talked about just needing support, learning collaborative. They thought was good to learn from their peers, allows for some problem solving, getting some feedback, and then just the same thing. They maybe some resource sharing. If they could get some consultation services, these would be things that could really help them get started. So that was sort of the provider side that was from our people that were in our learning collaborative. We've also done focus groups and surveys of community members. So I'm going to talk about that. We haven't finished wrong way. We've done 4 Zoom focus groups. Again, people are all over Southern California. 28 participants that we've had. We're still working on that sort of qualitative method. I guess they call it rapid, qualitative, not so rapid, really. It takes time. But I do have some survey data that I can share with you from our participants that give it from that side. Here's just some of the demographics of our participants, really, again, trying to get to Black, Latinx, MSM, and transgender individuals, and with diverse sort of backgrounds of, well, age, where they're born, some people clearly were having struggles in terms of work, worried about their housing, a lot of people on Medicare, Medicaid. So this is kind of the population that we're really trying to figure out, their interest in PrEP and how do we get LAI PrEP to them. So here, let me move my pictures over here, are some of the results. Most of them were actually on oral PrEP. Almost majority of people taking daily. There was a couple 2-on-1s and some people that were just coming off and on medication. I put this up because they weren't entirely all HIV uninfected, but we had a question that asked, why did you stop PrEP? And then 4 people said it's because I became HIV positive, which kind of like shocked me a little bit because I thought, that should be preventable, right? And that's kind of the rationale for maybe why injectable needs to be out there, or at least even still making oral more available. Only about 4 of them had tried a long-acting injectable PrEP at some point. Again, pretty good uptake of doxypep though, but this was encouraging that they knew, more than half people knew somebody that was on injectable. So that is a sign that people are seeing that and aware of that. And then overall, again, high sort of approval within this group for injectable PrEP. It suits them, appeals for them, applies to them. So that I think that there is some demand out there. And that's why kind of our next one is, well, okay, if there's that demand out there, how do we increase that? How do we, educate? How do we market it more to bring it into more use? So where are we now? So our next steps are going to be we're going to continue with these learning collaborations at least for another year. And our cabs, we're going to try and measure them, if changes in uptake over that year, see if we can move the needle at all. We're going to do some more focus groups and surveys on our community members about how to engage people about long-acting PrEP, and then we're going to just follow up over the year to get some final results and wrap up, and maybe present again on our final findings. I mean, I think what we're coming across is that there's a lot of big structural issues in how to delivery, and so that's why kind of we get. I was talking about how maybe a little frustration comes through when we talk to our cab because we just feel like that's sort of beyond a lot we do. So, but that's why I kind of pivoted to trying to get that feedback piece, to the pharmacies, to our legislators. How do we change policy? And because that may be what's needed more, but it's even bigger than that, probably in terms of the whole structure of how medications are delivered. And I think that that's not unique necessarily to injectable PrEP. I mean, I think that in terms of the commercial pharmacy, they're being squeezed by the PBM issue. And I know you notice we don't really have any real commercial pharmacies in our group. I mean, they're just not capable with their sort of flow to really be doing a lot of this kind of work unless there was some other incentive for them to do it. I would be amiss if I didn't just kind of plug my other study that I presented last year, because we are moving towards the last third of this. This is our CAR T therapy for HIV. Now, I think next week I'm going to probably enroll our sixth patient. This is a collaboration. I'm at the Sanford Stem Cell Clinical Center where we run I support about 40 different clinical trials, cellular medicine, gene therapies, stem cell therapies, and with our AVRC, of course, and City of Hope, who developed this CAR T product. And that's where they go to get their plasmapheresis and engineer the actual product and receive the product. We've had, like I said, I think our fifth person just got their plasmapheresis last week. Everything's going well. And we've really not seen a lot of side effects. This is a safety study, so we're not doing any treatment interruption other than the 4 days prior to plasmapheresis so that it doesn't infect with the lentivirus trend engineering of the CAR T cell. It uses sort of they select out these T cells that are reactive to CMV, and then they're engineered with sort of a BNAB sort of receptor so that they'll be able to target HIV. So right now we're just seeing, how well does it get into the body, stay in the body, how safe is it? And so far, not a lot of adverse events. So this has been pretty good. We're going to our last cohort, which is a dose escalation. And so we're still looking for participants there, but I just thought I'd give you a little update on where we're at with that. And then I think I am actually done a little early. Didn't go so slow last time, but I certainly want to acknowledge all the people that are on our research team, the funder, CHRP, obviously all our participants that are in our learning collaborative, in our CAB, and then our other sort of community participants. So with that, I'll take any questions or have a discussion about other people's experiences with this issue.
Great. Thanks, Sheldon, for a wonderful talk. We can open up to questions. I had one quick thing I was going to ask was, do you think with the all the education, do you think like the various sites at the beginning were more enthusiastic? And then as you started to teach them, there's more the reality of like what it actually takes to do PrEP and whether or not their expectation of how to really provide good PrEP services, I don't know, their evolution of understanding how what it takes really to do something well, the bars kind of gets higher, and that's perhaps why the scores kind of, what you showed, their their scores of feasibility kind of decline over time.
Well, I think there's a difference, and that was the cab that declined with yeah, but you people just wrote with their feet a little bit. I think and so if they're discouraged from the collaborative sites, they just may not show up again, and so you don't
Mm,
even get that survey data from them, right? But there's a little bit of both. I think there's people that we have sites that continue to show up even though they're not really making a lot of progress. They haven't been discouraged. They're waiting to sort of, still thinking about it, I guess, or thinking about how ways they could do. Other people, I think, have thought of this as just being too difficult for them right now. I mean, unless they really feel like this is an important thing, why persist, right? So they have to have an interest that this is important to their, patients that they see, and then they'll persist and hoping to hear, and then they are learning techniques, and we really don't push that you have to be perfect.
mm.
What my point is that, as long as, the idea is just get out there and start doing it, would probably be, you want to have some quality and good practices, but you don't have to be Owen Clinic, which is, really exemplary, right?
Yeah, and I would say, I've had some of that experience with working with the AIDS Education Training Center. We're working with La Maestra to try to help them implement PrEP, just even oral PrEP initially. And it's really taken a lot of effort and time. And then we'd start talking to them about the long-acting PrEP, and they just don't have any of the infrastructure. And so we've kind of decided to provide them support and just have them send the patients to us. But I can foresee that this is an issue nationwide, right, for people. So yeah, thank you for that. I'll just read. I don't know, or Jill, do you want to unmute for a quick sec and read your comment?
Sheldon, you just made the point about, the larger pharmacies, and I'm sure you remember that there are big negotiations between CVS Caremark with Gilead for lenacapavir, and I think this is, pretty remarkable that they've come to an agreement. I don't know, what's happened with cabotegravir, but these are the things that need to happen in order for us to move this forward. I mean, the fact that, even at Owen, which does a great job, anytime we start to see a new patient, the very first question is, what is their insurance? Do they have secondary coverage? Maybe if that's, what pharmacy does their insurance require them to use? It's a horrible headache, and that's why someone like Christian and Alan before him and all the other amazing people that have moved this forward, are critical to programs like this. And I don't know, how you do so much of this without people who really understand the ins and outs of insurance plans and, medical versus pharmacy benefits to get it. And then the policies, it's so wonderful that you're trying to involve politicians in this, but there has to be like monstrous policy change for this to really work. And we're talking about California, right? Where we do have policies that are supportive of this. So anyway, I'm not sure what I'm saying other than to support what you're saying. And again, I'm always a little suspicious of things that happen, but this CVS Caremark with, twice yearly lenacapavir does seem to be a big step forward as far as coverage.
Can I piggyback on you, Joe?
Of course, but you now wear a Gilead hat, so you have to declare.
Yes, yes, I'll declare that, but not wearing my Gilead hat. Even from when we started UCSD, I was very impressed to see how quickly things happened with Len compared to cabotegravir. So I think we are moving in the right direction, right? We saw the uptake for cabotegravir it took a while for the insurance companies and everybody else to kind of uptake, and the information we're getting now is that Len is at 90% of access right now, which is nowhere where Apertute was within 6 months of launch. So I think we are moving in the right direction, that the insurance companies are realizing that these are, they're good drugs and that people need to be on it. So
Good to
Great.
hear.
Thank you. So there was a question from Heidi. Can you explain a little more of the AB 55 bill and how will this help access for PrEP?
Yeah. So I think it was Baby 554 introduced by I forget the senator from Los Angeles, and the idea was that it would state that in California that a pharmaceutical company couldn't uh, require the prior authorization for a pre-exposure prophylaxis. And then the other thing that was really important out of that bill was how it gets reimbursed. So this is a part like I don't get involved in the reimbursement part so much from my side, but I know that there is, so on the pharmacy side, there's a pharmacy benefit and a medical benefit. And the medical benefit is to cover like a doctor's visit or when people come to the clinic versus payment to the pharmacy. And that makes a big difference. So I guess the preferable payment system for the pharmacies is making it always a pharmacy benefit, and that makes it more. I think that allows them to recover costs better. So that's how I understand how it would make things easier. There really is under the hood, really a financial issue at the pharmacies beyond just some of the other just hassles that they need to face to deliver this medication.
Anik?
Thank you for that really interesting presentation. I had two very tiny practical questions. I was curious about the storage life of the 6 month or the cabotegravir. I just kind of don't understand why, if it's big pharmacies, it couldn't be centralized in one pharmacy and they could store two or three, kind of injections just in case somebody needs them. But I'm thinking maybe it's a very short storage life.
I think that it's actually on the longer side. I don't know exactly. I'm just looking it up. It says that I don't know, injectable. Let's see if we show. I'm trying to look up what it is. I mean, injectable.
Neither product needs to be refrigerated, and they have relatively long expiration dates. Yeah.
Looks like it says 36 months for long acting. So it's pretty long time. But you're right. I mean, I think that that does seem like a long time. But then you are paying $20,000 to get a bunch. So that's not an insignificant amount to just have it sitting on your shelf. And then of course you have to get and even so they could probably do that if people had, the cash for that. I don't know the budgets of pharmacies and how much they're laying out for the medications that they have in stock. That's a whole nother world to me, and I don't know if anybody else can answer that, and how much this would be impactful. I think the concern is that if it gets wasted or if insurance doesn't cover it, there's that issue, and making sure that if there's a prior auth, that you have a written sort of authorization that they're going to pay for it.
Yeah, makes sense. And the other question I had, it was about a comment from, I think, one of the pharmacists about like taking ages filling up those spreadsheets. I was wondering, I mean, I'm surprised that like either of the pharmaceutical companies hasn't produced a software or, like an automated spreadsheet that organizes visits for patients or something like that it would all be done automatically.
Great idea. Yeah, I think that, that would be, there's your next Gilead project, Jill.
I can add Vive does have a software program available for tracking and inventory management, etc., for their products. but we have not used them because we use our own system, and it's an outside program that would require patient data, and UCSD is not keen to that, but there is something available.
And could, for example, that program sorry, I can't speak this morning, may be made available? Like, could it be made open source? Or could other programs could there be a repository of softwares that are open access so that pharmacies, clinics, etc. can use them?
Yeah, I don't know. I think that I only know they've been offering them to clinics. I don't know what they've engaged pharmacies, with in terms of using the software, but
Yeah, but I mean, even the one that is used at Owen Clinic, would that be relevant for other clinics, or it's so specific to the system that Owen Clinic uses that it wouldn't be translatable to another system?
we use a combination of Epic and Excel spreadsheets, so it's not something that probably could be, it's just Excel spreadsheet tracking, to be honest with you, because Epic does have some modules that might lend to doing this type of thing, but again, that's specific to Epic, so not at this point, really.
Secure spreadsheets. You always have to
Of
say
course,
secure, right?
yes, of course.
But I mean, if it works, maybe that Excel spreadsheet could be
Well,
shared with other clinics, right?
Well, there are clinics that have incorporated into Epic modules that, for instance, we're working with Planned Parenthood for lenacapavir. They created a module through Epic to track appointments and injection times and all this stuff. So it's doable through Epic and through EMRs. So I guess you just have to talk to them. Or if you want to talk to people, I'm trying to get in contact with Planned Parenthood and see their system. I'm curious how it works. But I know that they created a whole thing just to keep track of long-acting injectables.
Yeah, I think the challenge if you're talking about going to pharmacies is, a lot of them don't use Epic, and that's always the problem is everyone's using different systems to process, fill prescriptions, things like that. So it's hard to get something that's synced across all different pharmacies.
All right. Any other questions, comments?
I wanted just to mention, cis women make up 20% of new HIV infections, and we finally have a long-acting injectable. Well, I shouldn't say finally, like we have more PrEP options that I think are actually more mm, interesting for this population. It has been very challenging historically to get cis women, even who identify and know that they're higher risk, to take up PrEP. And now we have something that is actually works for the schedule and that people are interested in. I'm making more of a comment and asking the question of, can we get women involved in some of these studies perhaps so that we can hear what their opinions and voices are, so we can actually start getting PrEP out to these cis women, particularly those women of color who need it.
And that's a good point. I mean, that would be a great grant application. I know as well from just that the stigmatization of HIV medications is higher in women is what I've experienced in talking to people, and so injectables are actually a more attractive for cisgender women for therapy, and it would be a population that would probably have higher uptake if there was like you said, if there was a little bit more push on that side.
I think a lot of it has been that the marketing has not ever really been to cisgender women. And so the health education remains pretty low, in addition to just thinking that there isn't risk because they are cis women, and that again goes to education. So I am starting to see cis women agree to take Yes2Go, and I can't tell you how excited I am, having been in this for so long. I think it has I think Yes2Go particularly has an opportunity here, but we're going to be behind if we don't actually include them in studies early on, I think.
Yeah,
I'm going to argue against that. I think we've made some good movements, Sarah, with including women in studies. Not, I agree with you, but I think there's definitely been a big push in the last few years, and I do think there's been better marketing to include women. Purpose 3 is all cisgender women in the United States, which enrolled very, very quickly. Purpose 365, at least at our site, 3 of 13 participants are women, which is a big number overall. And Anik and I and Nimish have a study where we're going to be partnering with a mammography unit, where we can actually try to get women who maybe know less, about this to consider long-acting injectables. So I do think the work is happening. I agree with Sheldon. It is so different for women to be open about their sexuality, their lives, what they're doing, compared to, gay and bisexual men and transgender individuals. And that'll be a big fight. And it goes back to, it goes so deep into stigma, but I do think there have been efforts made. So maybe
Well,
just,
I
yeah.
and I'm not saying that. I mean, the fact that Yes to Go is we can give it to cisgender women. I mean,
And
that's a win.
anywhere, and in
So
most
it is
places
a
on their
win.
body.
It's just remembering that we need to include them at every
Yeah.
phase, right? And so we've been so focused on these higher risk groups that I think we're still forgetting that there's a lot of disparity, and again, particularly women of color, and I just want us to be mindful, and try and include them, because I think we have an opportunity, a real opportunity. Instead of creating more disparities, I think we can actually employ this and get this out quicker.
I have to agree, and I brought this up at our national meeting yesterday at Gilead. What I can share, our direct-to-consumer ads just came out on Sunday. You will see that the first ad is tailored directly to women. The position from Gilead is that we need to break down the stigma that this is only for gay men, and so you will see the change in marketing will be very targeted to women and straight couples, and so hopefully that would change mindset a little bit.
That's a great place to start. Like the marketing is
Look,
huge.
yeah, look
Then
at
the
the
health
ad.
education. That's
Super
how.
Bowl,
make
Super
money,
Bowl
right?
halftime show will be there. Halftime show,
Okay,
Super
I'll see
Bowl.
it.
Ooh.
Thank you very much, Sheldon.
All right. I think we're out of time.
We are. So thank you, Sheldon, for a wonderful presentation and great discussion, everyone. Have a great weekend, and we'll see you next time. Thanks, everyone.